Participants are asked to remain muted for the duration of the webinar. If you have any questions for the speaker, please type them in the chat box, which is located in the lower right-hand corner of your dashboard for GoToWebinar. If you have any technical issues, you can send me an email to jmulligan@acfaom.org. I'm very happy to have you all on the line today for today's webinar, and I would like to introduce our presenter, Dr. Brody. Dr. Brody is an expert in health information technology. He is a member of the HL7 EHR work group, where he works on developing standards for use of EHR systems, the HIMSS physician community, where he is a member of the physicians committee. He provides HIPAA consulting services to doctors, EHR vendors, orthotic labs, and data centers. He's lectured on the topic of health information technology and HIPAA compliance across the country to various audience both within and outside the podiatric community. And with that, I'm going to turn it over to Dr. Brody. Dr. Brody, thank you for today.
Well, thank you for that kind introduction, Jennifer. We're going to talk a little bit today. Actually, we're going to talk a lot about meaningful use stage 2. Now, hopefully at this point you're aware that approximately 2 months ago, CMS released an update to stage 2 of meaningful use, which made some significant changes and actually is moving in the direction of making meaningful use actually meaningful and applicable to us as providers, as opposed to what it was, which is really a lot of busy work. Meaningful use, in the process of becoming more meaningful, also has become easier for us to meet because a number of the items that were basically nuisance items have been removed. Meaningful use for 2015 stage 2 is a little bit different from 2016, and we're going to talk about both, but the focus here really is to help you be prepared to meet stage 2 of meaningful use for next year. If you have any questions about meaningful use for this year, I'll be glad to entertain them at the end of this webinar, but really let's focus on what you need to do next year so that way you can be a meaningful user and can achieve the benefits of meeting meaningful use in 2016. So basically, we're going to skip really the BS in this, and we're going to talk about how we can make it meaningful, how we can make the software work for you, work for your practice, to achieve improved quality, and actually possibly even achieve some improved reimbursement and income by utilizing some of the tools that certified software has to offer for you. Need to go through some disclaimer information. I am the Health Information Technology Consultant for PICA. I'm a technical editor for Podiatry Management Magazine. I'm the Chief Compliance Officer for SAMI ICS Software, a member of the HIMSS Physician Committee, a member of the HL7 EHR Work Group. I work with the Standards and Interoperability Framework for Standards of EHR Technology. I'm a clinical consultant for Baker Labs, and I'm the CEO of TLD Systems. It's also important to realize that as far as meaningful use goes, all the measures of meaningful use can be audited by CMS should you claim any incentive money, and I work with PICA representing providers who are audited for meaningful use. The first, and this applies to 2015, very important change for 2015 if you are testing this year, is that meaningful use for 2015 is any 90 consecutive days. But it's very important that you register with your state's immunization registries and syndromic surveillance registries now to allow you to meet those particular measures. Meaningful use stage 2 used to consist of 17 core and 6 menu measures. It has been reconfigured, and now meaningful use stage 2 consists of 10 objectives. Now we're going to look at the old measures and compare them to the objectives, so that way you could...
Sorry, I don't mean to interrupt.
Yes?
I think your screen is paused on the first slide.
Okay, thank you. Let me take a look.
Okay. Okay,
okay.
Much better now. I can see it. Thank
okay.
you.
Very good. Thank you. I apologize about that.
No worries.
Meaningful use now consists of 10 objectives. We're going to look at those objectives and compare them to the old core and menu measures and see how they fit together to allow you to get a better grasp of what is going on with meaningful use today. The first objective is computerized physician order entry. Computerized physician order entry is unique in that this is the only measure of meaningful use that must be done by a licensed professional. And under this particular measure, the medication orders, the laboratory orders, and the radiology orders must be entered directly into your healthcare system by a licensed professional who is allowed to write these orders as per the state, local, and professional guidelines. So this is something that cannot be delegated to your medical assistant. You must do this yourself. This is really very helpful for a number of reasons. If you put the orders into your computer, it's easier for you to track what orders have been placed. And therefore, it's easier for you to track when you get the results in. So having the results available to you, or even more importantly, knowing when you've placed an order that you don't have the results for, can be very, very useful. For example, if you send somebody out for a CT or an MRI, and you run a report and get a list of the tests that you've ordered that you don't have results on, it gives you the opportunity to reach out to the patients who have not had these tests, find out why they haven't had the tests, and get them to go for that test. This is an advantage to you from the perspective of med-mal because it takes away the ability of somebody to claim that you failed to follow up on a test that you ordered. It also is a major revenue issue because if a patient does not go for that test, they're not going to return to your office for the follow-up care in order for you to provide them with the necessary treatment, so you've missed an opportunity for billable services. More importantly, you've missed an opportunity to provide that needed care for the patient to get them better and to solve their problem and to have a positive outcome. So as a result, the patient who does not have a positive outcome will not be satisfied, but if you do reach out to the patient and you get them to go for the test, have them return to your office, and then provide the treatment, you will have a positive outcome, more satisfied patients, and you're going to provide better quality care. So by utilizing this measure and then utilizing the tools within your EHR to follow up and track and make sure that the tests that you ordered are completed, you're going to have a myriad of benefits, both in terms of quality of care and in terms of the bottom line for your practice. Now, there are thresholds you have to meet for each of these three aspects of computerized physician order entry. If in 2016 you are supposed to be at stage 1 of meaningful use, or you were supposed to be at stage 1 of meaningful use, your medication order threshold is 30%. That means 30% of the medication orders or prescriptions you write must be done through your EHR, and you're exempt from the radiology and lab orders section of this particular measure. If you're supposed to be at stage 2, your threshold for medication orders is 60%. 30% of the radiology orders, and that's X-ray, CT, any imaging study, must be in your computer, and 30% of your lab orders must be done in the computer. Now, it's important to realize that if you do an X-ray in your office, that is a test that you have ordered, and you need to put that into your EHR also, and it counts towards the 30% that you have to do. So put the orders in even for the X-rays that you order in your office. When you're testing for meaningful use, there are some exemptions. If you've ordered less than 100 medications, you can be exempt from the medications portion of this measure. If you have less than 100 lab orders, you can be exempt from that portion of the measure. And if you have less than 100 radiology orders, you can be exempt from that portion of the measure. So it's possible that of these three, you only have to maybe do the radiology orders if that's the only item you have over 100 orders in. The second measure of meaningful use is e-prescribing. E-prescribing is taking those medication orders that you put into your computer and hitting the button to transmit it to the pharmacy electronically. because once that medication order is in the computer, you have a choice of either printing it and handing it to the patient or transmitting it to the pharmacy. You want to transmit it to the pharmacy because when you transmit it electronically, as opposed to writing it or putting it on paper as a typed thing, you're ensuring that it makes it to the pharmacist, and that avoids prescriptions being lost or issues with prescriptions being modified. And how is this an advantage? Because if the prescription cannot be read by the pharmacist, they're going to call you and ask for clarification. This will save you the need of picking up the phone and reviewing prescriptions with the pharmacist. The threshold for this, if you're supposed to be at stage 1, is 40%, and if you're supposed to be at stage 2, the threshold is 50%. This measure also has an exemption, and that exemption is if you wrote less than 100 prescriptions, you are exempt from this particular measure. We had measure 3, demographics. This was a measure that was really busy work where we had to collect information on the patient's sex, race, ethnicity, date of birth, and preferred language. But under the new rule, this particular measure is gone, and we no longer need to do this in order to meet meaningful use. The fourth measure was vital signs. Vital signs was recording a patient's height and weight and blood pressure. There were 3 items that we had to do, and we had to record them in the chart. Under the new rule for meaningful use, this is gone. But even though this is gone, it is important for other federal programs, specifically the PQRS program, that you actually continue to record the patient's height, weight, and blood pressure. And when we're talking about PQRS, there's an additional parameter that we have to be aware of. For PQRS, we can't just record it, we must actually take these values and measure them from patients in our office, and it is fully permissible to have one of your staff members measure the patient's height, weight, and blood pressure for you. This measure was a difficult thing to do because it's extra work, but I've lectured many places, and very often I ask doctors in the audience, has anyone ever encountered a patient with a dangerously high blood pressure? And invariably, a few people raised their hands. And they reacted in such a way that they sent the patient to the emergency room or directly to their PCP in order to be treated for a dangerously high blood pressure. And I'm sure that there's at least one podiatrist out there, if not more, who by measuring the blood pressure, identifying a dangerously high blood pressure, prevented a stroke or worse for one of their patients. So by doing this and measuring this for our patients, we are potentially doing life-saving care for these patients by getting them the care they need before they have a stroke. The next measure that used to be part of meaningful use was smoking status, recording the smoking status for our patients who are 13 years of age or older. And under the new rule, this is no longer part of meaningful use. But this is still an important aspect of PQRS because PQRS has a measure where we ask the patient's tobacco status, not smoking status, but tobacco status. And those who are using tobacco get tobacco cessation counseling. So it's still something you want to do to successfully participate in the PQRS program, even though it is no longer part of meaningful use. The next measure, which is a very, very significant measure under Stage 2 of meaningful use, is clinical decision support. Clinical decision support is utilizing tools and evidence-based medicine to improve the quality of care we provide. And how does this work? Well, first of all, each clinical decision support rule must be supported, as I said, by evidence-based medicine. In addition, each clinical decision support rule should be related to a high priority clinical item. So let's take a look at maybe a clinical decision support rule that you might want to implement. One could be related to doing a vascular analysis. There is evidence-based medicine that indicates that if the patient has signs of peripheral artery disease, doing a Doppler scan or non-invasive vascular study is indicated. So when someone comes in with poor circulation, if you do a non-invasive vascular study as a screening test, and you identify the patient has significant peripheral arterial disease, and you refer them to a vascular specialist, you are providing a very important quality care to that patient. In addition, you have just done a billable service which helps your bottom line. So in this case, by utilizing clinical decision support rules that are appropriate to your patients, it helps you to improve quality of care and it helps you to improve your bottom line. You can find clinical decision support rules that you can implement that apply to various treatments and various diseases that you can provide. And when you find clinical decision support rules that remind you to provide services that are A, important, B, provide quality care, and C, are billable, you can leverage this particular tool to improve the quality of care you provide and once again improve your bottom line. As I said earlier, the clinical decision support rules must be supported by published guidelines. If you want to look at some published guidelines, there is a government website called guideline.gov. If you go to that site, you can put in a particular condition such as plantar fasciitis, peripheral artery disease, even bunion, and it will come up and show you all the existing guidelines that exist for that disease state. And then you can look at those guidelines, look at the recommendations in those guidelines, and build out your clinical decision support rules. You will probably need to communicate with your vendor to determine how to use the tools in your software in order to build out those rules for you. The next measure, which is still in meaningful use, is to provide patients with their health information online. And this is a two-part measure. The first part is that we must provide, and key word here is provide, patients with the ability to view their health information online. Providing the information means giving them everything that they need in order to access the patient portal. If you hand them a piece of paper in the office that tells them what their username is, what their password is, and what website to go to access their health information, you have met part one of this measure. Part two of the measure is that patients must visit the portal and actually view their information, download it, or transmit it. So there are two parts to this particular one. The first part's relatively easy, giving the patients the information. The second part requires that the patients actually go online and view the information. And this can be difficult and requires some work on your part. I personally am not a fan of part two of this measure, because it requires patients to do something outside of your office, and it can be very difficult to control a patient once they walk outside the door. So this is one of the most difficult part of meaningful use. But you can educate your patients about the tools in the portal to try to encourage them to go to the portal. You can push patient information to the portal. You can have the patient go to the portal and request medication refills. You can actually, in some EHR systems, use the portal so patients can go to the portal to pay their bills. Or you can use the portal to send the patient clinical summaries and health information. So the portal can be leveraged to your advantage, but you have to get the patients to visit the portal. Now, there are some thresholds for both of these measures. For part one, which is giving the patients access to the portal, whether they actually visit it or not, over 50% of your patients must be provided with the information necessary such that they can access the portal. For part two, if you're stage one, you're exempt from this. For stage two, only one patient has to visit the portal in order to meet part two. So whereas it is difficult, you can just get one patient, and if necessary, have a tablet available in your office and have your office assistant assist the patient in visiting their portal. The next measure of meaningful use that used to be there was clinical summaries, which was the requirement that we provide a clinical summary for each office visit. This is now gone from meaningful use. We no longer need to do this. Measure number 9 is to protect health information. This is the process of going through a HIPAA security risk analysis and implementing the necessary safeguards in our office to protect the integrity, availability, and confidentiality of our patient data. I said earlier, meaningful use users are being audited by CMS. And what they found is about 23% of doctors who are audited for meaningful use fail the audit. The most common reason for an audit failure is that the doctor did not perform a proper HIPAA security risk analysis to protect their health information. In addition to losing the meaningful use money, if you don't do a HIPAA security risk analysis and implement security, you're at much higher risk of a HIPAA breach. And a HIPAA breach can be very expensive because you can have fines, you can have to provide credit monitoring services for your patients, and if it's a large breach, it will make the newspapers and is very bad PR for your practice. So it's really something you want to do to protect the PR of your practice. The next measure that was in meaningful use was to incorporate lab results directly into your EHR. This was a very difficult measure because it required an electronic interface with the labs, and this is now gone from meaningful use. The nice thing about it is that if you do have that electronic interface, it does allow you quick and easy access to your lab results. So if you're doing labs and you can get that electronic interface and get those results into your computer quickly, it is an advantage to you to still utilize this tool even though it's not part of meaningful use. Measure number 11 was patient lists. We had to print out a patient list. It was silly. It was busy work. It is now gone from meaningful use. But that patient list, we could print out a list of our patients who have diabetes, who haven't been in for over 6 months, who have to come in for a foot exam. We can print out a list of patients who have received orthotics in the last 2 years and haven't come in. So the tool is still there in our EHR. And we can take that tool and we can utilize it to identify patients who have not been in our office for a while, who are indicated for follow-up for one medical reason or another. So by utilizing this tool in your EHR, you can make sure that patients don't fall through the cracks, that they are not lost for follow-up, they get the care they need, and you can bill for providing that necessary care to your patients. The next measure of meaningful use was preventative care, very similar to patient lists. It's another tool to generate a list of patients by conditions, and under the new rule, this is gone also. Once again, because it generated a list of patients by conditions, it helped you to fill your waiting room, remind patients to come in for medically appropriate care. The next measure of meaningful use, measure number 13, patient education, is still part of meaningful use. Patient education measure is that your EHR is set up so that way it reminds you to provide them with clinically relevant patient education. For example, if a patient comes in the door who happens to have diabetes and neuropathy, the system can remind you to provide the patient with the brochure that gives them risk factors for neuropathy and things they need to do and things they need to avoid to prevent injury to their feet. The key here is this: the education, in order to account for this measure, must be identified by the EHR. So simply providing patient education does not meet this measure. The EHR has to actually pop up and remind you to provide the education, and you have to provide the education reminded by the EHR. That means that you're going to want to configure your system to remind you to provide the patients with the education that you have in your office. It could be brochures that you purchase, brochures or information that you create yourself, but your EHR needs to be configured to remind you to provide this important education to your patients. And this patient education is a great risk management tool, because if you provide them with education and you document it, a patient can't claim that you didn't tell them about something. This is especially significant when providing them with preoperative education, because that can be the process of going through an informed consent and going through the risks and benefits of a procedure. So if that's part of your educational process and you document that you provided the education, you can eliminate the ability of a patient to say, the doctor never told me this was a potential complication of my procedure. So it creates a more informed patient, it creates a more engaged patient because they know what's going on, and it provides you with better documentation to protect you from any potential malpractice case. The threshold for this particular measure is 10% of your patients. 10% of your patients must receive patient education. Now, if you were supposed to be at stage 1 at this point in time, you can claim a special exemption to this measure because patient education was a menu measure for stage 1. It's a core measure for stage 2, but menu for stage 1. Therefore, under the new meaningful use rules, which don't have core or menu measures, if you were supposed to be at stage 1, since this was supposed to be a menu measure, you can claim an exemption stating that you did not intend to meet this menu measure, but that special exemption only exists for 2015. That special exemption does not exist in 2016. In 2016, whether you were supposed to be at stage 1 or stage 2, you must meet this measure. Measure number 14 is medication reconciliation. Medication reconciliation is the process of looking at 2 lists of medication from the patient side by side in your EHR, reviewing them and determining which medications the patient is currently on, reconciling them, and making sure that the list of medications that you have in your EHR is the most current list. You can compare 2 lists and not make any changes, saying your list is most current already, and that is still reconciliation. You need to do medication reconciliation anytime you receive patient from another care setting and they arrive with something known as a transition of care document. So each time a patient comes to you with a transition of care document, you must do medication reconciliation. The transition of care document can come from a hospital after discharge. It can come from a primary care provider who is referring a patient to you. It might even come from a podiatrist in another state with a patient who is moving to your state for their care. In all of these cases, whenever you get the transition of care document, you need to perform medication reconciliation. And this is simply good medicine because having the most up-to-date list of medications for the patient in your system and available to you allows you to make better medical decisions. The threshold for medication reconciliation is that you must do it at least 50% of the time that a patient arrives with this transition of care document. Once again, this was a stage 1 menu measure. So for 2015 and 2015 only, if you were supposed to be at stage 1, you can claim a special exemption to this measure. There is also an exemption to this measure if during your reporting period you did not receive any transition of care documents. That transition of care document is the next measure. The transition of care document is any time you refer a patient to another care setting or another doctor, you generate a transition of care document. A transition of care document is a document that has vital information on that patient. It has their demographics. It has their list of medications. It has their list of allergies. It has their problems. It has a number of other things. And it has one more piece of information that is really, really useful to the doctor who is receiving that patient. And that additional piece of information is why is the patient being referred to the other doctor. So when you send a patient to another provider with a transition of care document, they know why you're referring the patient to them. And in fact, if you receive this transition of care document, you know why the patient that is sitting in your chair was sent to you by the other doctor, which gives you a clue as to what is going on with the patient, because as we know, sometimes patients are not the best historians. So this is really a very, very good tool that allows you to effectively communicate with other doctors in the community and work collaboratively with them to provide quality care for the patients. So in terms of outcomes, it's a major issue because you know what's going on with the patients, you know what the other doctors are doing, you know why they're referring them patients to you, and they know the same thing. So it's a benefit in terms of quality of care. It's also a potential benefit to the bottom line of your practice, because if you're able to more effectively communicate with the providers in the community and they can more effectively communicate with you, they will want to work with you more because they will know that you are going to be a good partner working with them to provide quality care to your patients that you're seeing. In addition, because this is a meaningful use measure, and because one of the aspects of this particular measure is that a certain number of the transition of care documents need to be sent electronically, if you're able to receive these documents electronically, you can market it to potential referral sources. And those potential referral sources will say, hey, great, I can send this doctor the transition of care electronically, which means it helps me to meet this measure, and that will help you to build your referral base. So by utilizing this particular measure and marketing the fact that you can receive these documents electronically, you can improve your bottom line. You must create the transition of care documents and transmit them electronically 10% of the time. You can claim an exemption if you have less than 100 transitions of care, and if you're in stage 1, you have an automatic exemption from this particular measure. Measure number 16 is still in meaningful use immunization registries. As podiatrists, for the most part, we do not provide immunizations. But if you do, you must submit the information to immunization registries. I say if you do because some people may consider a tetanus shot an immunization, and some podiatrists may provide it. Obviously, we don't provide any childhood immunizations. If you do not provide immunizations, you have an exemption to this particular measure, but you should register with your state immunization registry, or at least try to get an account with them, just to make sure you're covered in case they want to see it. This is good for the state health department, but it's really not related to the practice of podiatry, but you still need to contact your state health department and see if you can get an account. To contact your state health department, go online, Google your state immunization registry, and you'll either find a website where you fill out a form, an email address to send a request to, or a phone number. Just follow up to the best of your ability. Now, immunizations for stage 2 have been bundled with syndromic surveillance and specialty registries. So for stage 2 of meaningful use, we have to submit to 2 of the 3 registries. Now, syndromic surveillance, for the most part, state syndromic surveillance registries are not really tracking the things that we as podiatrists treat. Nonetheless, they may, or we end up treating people with things that are being tracked by the state syndromic surveillance registry. So we need to go to our state, find the syndromic surveillance registry, and try to get an account with the syndromic surveillance registry. Now, with both the syndromic surveillance registry and immunization registry, the state may say, sorry, we are not accepting information from podiatrists. If that is the case, just get documentation of that so you have it on hand should you be audited. The third type of registry that we might have to submit to is known as a specialty registry. Once again, for stage 1, you need to submit to 1 of the 3 registries if you can. For stage 2, you have to submit to 2 of the 3 registries if you can. If you can't and you have the exemptions, you are not required to do so. In addition, for 2015 and 2015 only, because specialty registries and syndromic surveillance registries were both menu measures, for 2015, a special exemption can be claimed that you did not intend to meet this measure, and therefore you can claim an exemption, which means you only for 2015 need to worry about immunization registries. Please go online and register with these registries to get accounts as soon as possible, and if you can get it, great. If you can't, get documentation that they will not provide you with an account. The next measure of meaningful use was secure messaging. Secure messaging is managed through that patient portal that we discussed earlier. And secure messaging is that a patient utilizes the portal to send you a secure message. This used to be a 5% threshold. Under the new rule, this only needs to be turned on in your EHR system, so it really does not require any effort on your part as long as you have certified software. You can leverage this in order to minimize the number of phone calls patients make to your office and have communication with patients in an asynchronous manner, hopefully reducing some of the workload in your office. The menu measures that used to be present, menu measure 1 was syndromic surveillance. It still exists, and we discussed that already. Measure number 2 of meaningful use, menu measure number 2, was electronic notes. Electronic notes are no longer part of meaningful use. We don't have to do them. Menu measure number 3 were medical images and results. That is also now gone from meaningful use. This was a relatively onerous measure, and it was a lot of work and a lot of technology and a lot of expense. We don't need to do this anymore. Measure number 4, doing the family health history. This is also now gone from meaningful use. We do not need to do this anymore. Measure number 5, cancer registries. Cancer registries are now bundled with specialty registries, and if you happen to treat cancer and you report to a cancer registry, you can use that for the meaningful use registry measure, which once again requires you to report to 2 registries. Now, when I say you have to report to 2 registries, and this can come into play in 2016, if you happen to treat cancer and you report to a cancer registry, and you happen to treat wounds, and you report to a wound registry, you are reporting to 2 specialty registries. That is 2 registries that you've reported to. You are done with that measure of meaningful use. And registered reporting is very important for 2016, so you want to start looking for registries you can utilize for next year. Menu number 6, any other registry, once again, that is bundled with the registry measures that we spoke about earlier. And the registries, especially if you have a registry that is specific to treatments, to diseases that you treat, you can help get information into the registries to allow you to track outcomes and improve the quality of care that you provide. And that's really an overview of what has happened with meaningful use, with some ideas on how you can utilize the information in the EHR and utilize the tools in the EHR to allow you to provide better quality care and improve the bottom line of your office and make your practice more meaningful to you and to your patients. Now, if you have any questions, if you look at the top right of your screen, there is an orange arrow that will open and close a control panel. Within that control panel is a box for you to enter questions. So if you have any questions, please type them into the box, and we will stay on for a while and try to answer everybody's questions.
Thank you very much, Dr. Brody. We'll give some time for some questions to come in. But just a reminder, everyone, this has been recorded and will be available on our live learning center. And let me just check for some questions. If anyone thinks of questions after the session, you can email me at jmulligan@acfaom.org, and I can forward it to Dr. Brody to help.
I assume from the silence we don't have any questions yet?
Looks like we don't have any yet.
Okay, which means either I was perfectly clear or people are too confused to understand what to ask, and I'm not sure which.
Maybe both. All right, well, if there aren't any questions, at least right now, you can email me later, but if not, thank you very much, Dr. Brody. Thank you for taking your time today to give us this webinar. Don't see anything coming in. Oh, got one. Risk analysis. Please expand.
Risk analysis, please expand. Okay. The risk analysis is the process of looking at the risks that exist to your patient data. And you have to look at risks to the data being compromised in a manner where somebody who does not see the information gets to see it, which is a breach of the patient's confidentiality. You have to look at it in terms of the chance of the computer information being damaged, which is a breach of the integrity of the data, or you have to look at it in terms of the data being lost or unavailable, which results in unavailability of the data. Now, a common problem that is going on in the medical community and in the world in general is a virus known as ransomware. If you happen to click on a link in an email that has malicious code or visit a nasty website that gives you this type of malicious code, ransomware will start to run on your computer and encrypt all of your information. If it gets encrypted, when you try to open up your computer, you will find that you cannot get access to any of your data, and a message will pop up saying, if you want your information back, please send us a check for $10,000. And if you do not send them the $10,000, you have lost access to your data. You need to have malware, anti-malware software running that will protect you from this ransomware, because that type of situation, whereas the patient's confidentiality has not been breached, the availability to the data has. So the risk analysis is looking at the risks such as the ransomware and determining what is the chance that it will happen and what steps do you need to make to prevent this from happening. Ransomware is just one type of risk. Another type of risk might be someone breaking into your computer and accessing the information and downloading it and using it for their own purposes. Another type of risk might be somebody breaking into your office and stealing your computers. Another type of risk might be having information on a laptop and losing the laptop at an airport or a restaurant or leaving it in a taxi cab. Another type of risk is that someone will be leaning over the counter and be able to view patient information on a screen at your front desk. These are all risks to the either confidentiality, availability, or integrity of the data. You have to look at what you're doing in your practice and at the risks that exist to your data, and then come up with an action plan to minimize any of these risks being realized and resulting in either patient confidentiality being compromised, the patient information being damaged, or the patient information becoming unavailable. So the risk analysis is a document that looks at the risks, looks at what you're doing, and comes up with an action plan that says these are things I'm going to do it better.
All right, and a follow-up question to that was how much paper documentation is needed. CMS offers a risk analysis tool. Do you recommend using it?
There are lots of risk analysis tools out there, and as long as you understand the rules and you understand the risks, these tools can be great. The problem with most of these tools is it allows you to identify where you have information in your office, but they really do not help you develop action plans or risk mitigation plans. And therefore, many of the tools only allow you to do half the job, and if you are audited and have only done half the job, you will find that you will not pass the audit. So you really need to make sure that when you do your risk analysis, it includes an action plan that mitigates the risks that you identified. In addition, your risk analysis must be very specific to your practice, to your office. It must include and identify the computers you use, the software you use, the configuration of your network. All of these things need to be in your risk analysis, because the risks to one type of computer and one type of network are different than the risks to another type of computer, another type of network. The risks to an office that are on the ground floor in an area that is prone to floods are different from the risks of an office that's on the third floor of a medical building. So everybody's risks are different because of their situation, and therefore these tools can be very difficult because the tools are built as one size fits all, and as we know, our practices are not one size fits all.
Thank you. Can you comment on the risk analysis HIPAA manual available on the APMA website that allows you to do your own manual?
The document that's available on the APMA website, if you look at it at the very beginning, it tells you right away this is a template. It's a very, very good template, but once again, it's a template which makes it a one-size-fits-all situation. And unless you take that template and go through the process of looking at it and making all the appropriate modifications to it to address what's happening in your practice, then you have not done a risk analysis. You simply downloaded a document. And that template does not walk you through the steps of determining what the risks are and what steps you have to take to mitigate those risks. That template is a very good set of policies and procedures that you would follow, which are administrative only, but really don't give you technical or physical measures. So it is a good start, but that in and of itself is not enough, and if you don't properly customize it to your practice and you don't properly come up with a risk mitigation plan, which is not really included in the template, it is not going to do the job for you.
All right, thank you. Is ransomware an issue for web-based storage of data, such as Practice Fusion or others?
At this point in time, I have not heard of ransomware being an issue for any online providers of backup services or EMR. So from their perspective, I'm sure it's an issue because they are constantly implementing technology to prevent ransomware from infecting their systems. So it is an issue, it's something they're aware of, and it's something that they're dealing with and putting in safeguards to prevent on your behalf.
All right, and last one. When and how will you know if you meet the meaningful use?
When and how will you know if you meet meaningful use? Well, to meet meaningful use, at the end of the year, in fact on January 4th, you will be able to go to the CMS website to attest that you have met meaningful use. And you will fill out some forms. They'll ask you to put in numerators and denominators and numbers that will come out of a report on your EHR. So you use the report in your EHR, you punch in the numbers, and as you punch the numbers for each measure, it will do a calculation right away telling you if you've met that particular measure. And if you meet all the measures and you answer all the questions properly, it will come back and say, congratulations, you have successfully attested for meaningful use, at which point you will be set up to either receive the check or avoid the penalty. That being said, when you do this, you want to make sure that you keep copies of all the documentation you utilized when you attested. So if your EHR gave you a report, print out a copy of the report, make a couple of extra copies, and keep them in a safe place. If you applied to be in an immunization registry and they said no, keep a copy of that in a safe place. Keep a copy of your HIPAA security risk analysis in a safe place, because you're going to need all of these documents should you be audited for meaningful use. And especially if you are audited for meaningful use in 3 or 4 years down the line, and in the process between now and then, you change your EHR vendor, you move your office, or things change, you might not have access to your EHR to generate a new report. So always keep hard copy reports of everything in order to make sure that should you be audited in the future, you have the documentation necessary on hand to pass that audit.
All right, that's all the questions we have. Thank you again, Dr. Brody. If anyone has any more that they think of later, again, you can email me. But I think that concludes tonight's webinar. Thank you.